I would like to invite the next speaker, Dr. Warid who will be talking on the modified Puttiplat operation for recurrent anterior dislocation of shoulder.
Good morning, everybody. I'm going to speak on modified Puttiplat operation for recurrent anterior dislocation of shoulder. I'm from Bhattacharya Orthopedics and Related Research Center, Kolkata. So, most unstable joint biomechanically and anatomically accounts for almost 50% of all the dislocations. Cause of the recurrent dislocation may be congenital, injury to the bone, capsule or labrum, rotator cuff, or injury to the ligaments. So it accounts for more than 50% of all the dislocations that are occurring in the body. So this is the brief anatomy of the shoulder joint, how the rotator cuff blends around the shoulder joint and maintains the stability along with the coverage by the deltoid. So what are the operations for the recurrent dislocation of the shoulder? So there are so many options we have available, that is the Puttiplat, the Bankart, the Magnuson stack, Bristow's, Eden Hibernate, and Bosche. So there are so many options. So we are using a combination of a Puttiplat operation and anterior block placement as a modification and evaluation of same for the results. So the study design was a total number of 40 cases were taken. Duration of study is 2005 to 2012. Age of the patients 18 to 50 years of age. Gender 34 males and 6 females. Right-sided 31 and left-sided 9 patients. So the operative technique was positioning was the normal, the V chair position or anything between the scapula just to open up the joint. The approach was the deltopectoral approach or the anterior approach of the Henry for the shoulder. This is the normal routine incisions that how you take for the deltopectoral approach. The coracoid process was osteotomized in all the cases. So the subscapularis and the capsule was cut. This is the most important thing that the modification we did. A quadrangular bone block taken from the iliac crest, that is a corticocancellous graft, which we take from the iliac crest. This picture is not quite clear, but then this is the shape of the graft which we take from the iliac crest, and this is bone block is inserted into an osteotomy site on the anterior inferior part of the glenoid. So this is basically what we do is the augmentation of the glenoid just to make the joint more spacious, more deep, so that there is very less chance of a dislocation later. Followed by we do a normal double raphe of the subscapularis, which is done in the Puttiplat operation. So this is the combination what we have done. The arm is kept in neutral and then double breasting of the subscapularis muscle is done. Care is taken not to put much tension. The wound is cleared over a drain as a chest arm strapping. So this is the closure, then the double breasting. In the post-operative rehabilitation, the strapping is removed along with the stitches on the 12th day. Shoulder mobilization exercises are started. Muscle strengthening, arm is kept in pouch and sling for 2 more weeks. So we have done all the scoring according to the Linom shoulder score based on the functional outcomes. So the complications are infection was in 3 cases, osteoarthritis in 2 cases, frozen shoulder in 1 case, acceptable average range of the motion, which is abduction 140 plus minus 20, external rotation 50 plus minus 20, and internal rotation 60 plus minus 20. So these are the few cases. This is a pre-op image. This is an immediate post-op image. You hardly find anything in the immediate post-op image. That graft is not really seen. This is the scar of the deltopectoral approach. This is the 18 months follow-up. And this is 1 year and 4 months of follow-up of this guy. He had a very good range of motion. Similarly, another case, pre-op 4 months follow-up, then 2 years of follow-up, 2 years and 2 months of follow-up, and again with a very good range of motion and a stable joint. Similarly, third case was again, this is the 6 months follow-up. So the discussion is using a combination procedures with modification gives good results, both in terms of stability as well as movement, when compared with the procedures used individually. So the most important part is that there is no recurrence in our study as has been reported with all the individual procedures, because all the individual procedures, if you see, there have been reports of recurrences of dislocations with individual, but in our study we have as of now we have not seen even a single case of a recurrence with this procedure. So the take home message is the abduction, external rotation and extension causes dislocation. The bone block deepens the anterior margin of the glenoid, offering resistance to dislocation. Subscapularis double breasting, it limits the external rotation and also the abduction. Thank you.
Thank you very much, Dr. Warid. Dr. Warid, I just wanted to find out a little bit more about the procedure. You
Yes.
have mentioned the coracoid osteotomy.
Yes.
What are you doing with the coracoid that you have osteotomized?
We are fixing it back again
With what?
with the ethibond. In our all the cases, we don't use anything, any screw or anything. We just use an ethibond to suture it back to the place.
And the
In,
reason
in the
you
proximal humerus fractures, we never osteotomize it, but in case of this procedure, we always osteotomize it.
and the reason for that?
Reason is that we give a complete exposure of the joint, because proximal humerus we can go into that without osteotomizing the subscapularis, because you just need to fix on the lateral side, but here you need to see the joint, the glenoid, and do an osteotomy and then elevate it a bit and put a graft. So the osteotomy, we did it in every case.
Okay.
Yeah.
Now that you have done an osteotomy anyway, any incidents of non-union of the coracoid, because it's only ethibond you're using to stitch it back?
No.
Have you
We
looked
have
at
not.
that?
We have not. Yeah.
Okay. Because just my impression that yes, your results are excellent. They're very good. 40 patients, no recurrence at all. You're
Yes.
taking a graft and by mechanical block to anterior
Right,
dislocation.
Exactly.
Yes, but what you have not included in one of the options of your surgical procedures is a latige procedure.
Okay.
Latige is one of the most common procedures now
That is
what
being
they're
done.
using worldwide.
Yeah.
But and it will be interesting if you compare. And if you're anyway doing a coracoid osteotomy, most latige procedures they are doing with just a subscapularis split,
Yes.
not even elevating the
Yes, yes,
subscapularis. So, and the incision is smaller. That is the most common procedure. So I'll be interested to find out if you
If we
compare the
it with
two,
lateral
latige, your modified Puttiplat procedure.
Yes.
But yeah, it's quite a good paper. Thank you very
Thank
much,
you.
Dr.
Thank you.
Warid. Any questions from the audience?
We don't we just make an osteotomy with an osteotome, a small, it's just a 2 millimeter thick graft. It's a quadrangular shape, but it's a very thin. We just have to augment the glenoid. We don't have to put a big graft or you mean deepen it more. It's just a slight increase in that angle. So we don't fix it with anything. We just make a slit with an osteotome, just a bit of thicker graft, just hammer it, punch it with a bone punch and a hammer, and that's it. And it fixes well. There's no question of any problem with that.
Okay, thank you very much, Dr. Warid.
Thank you.
I would like to invite the next speaker, Dr. Prasood. He'll be talking